عبد الرحمن شلون؟ وين عبد الرحمن؟ عبد الرحمن
هلا دكتور، هلا
موجود ولا؟
موجود طال عمرك، دائما موجود.
رفعت البرزنتيشن للشباب؟
رفعت.
ممتاز. طيب الحضور كامل نبدأ ولا شلون؟
توكل على الله.
طيب ممتاز. الجول بلادر ديزيز طبعا it is one of the main bulk of general surgery topics. الجول بلادر and the pathology of the gallbladder benign and malignant pathology. طبعا very common, it is important, and it is simple يعني for anyone understand the pathology and the clinical presentation. It will be very easy and enjoyable. طيب taking يعني basics of hepatobiliary anatomy, you can see the liver, the extrabiliary system, gallbladder, pancreas, and the duodenum. Let's see the biliary system starting from the liver. You can see up here, this is the left hepatic duct, and here is the right hepatic duct. They join together and form the common hepatic duct. It's very important to understand and to remember the names of each one. So they form together common hepatic duct. They descend down the common hepatic duct until it joins the cystic duct. After the cystic duct, it will be a common bile duct. After the cystic duct joining the common hepatic duct, it will be common bile duct. The common bile duct descend down until the duodenum, second part of duodenum. And here you can see the sphincter of Oddi, which is a physiological sphincter that opens to allow the bile to go to duodenum. So we go to the gallbladder pathology, and we will start by the most to the least common. So the most common pathology of the gallbladder, it's gallstones. It's cholelithiasis. So cholelithiasis, it is the most common biliary pathology. It is for asymptomatic in majority of the cases. So if we do an ultrasound for thousands of patients, we found the patient who's having gallstones, but he is not complaining. He's asymptomatic. Approximately 2% of asymptomatic patients develop symptoms requiring surgery. Inflammation of gallbladder mucosa can lead to excessive absorption of water and bile salts, leaving the cholesterol in high concentration. The cholesterol precipitate in many small crystals, which progress to large crystal of cholesterol stones. Okay. What is the type of gallstones? We have three main types. We have cholesterol stone, we have pigment stone, which is either black or brown, and we have mixed stone. The risk factor for cholesterol gallstone is three main, I can say three main risk factor, and each risk factor can have subsequent risk factors. So there is cholesterol secretion, high cholesterol secretion in old ages, female gender, pregnancy, obesity, and rapid weight loss. So in those conditions, the common is high cholesterol secretion. Impaired gallbladder emptying. Impaired gallbladder emptying because the gallbladder wall it's contain muscle, so all muscles of the gallbladder wall it's contract to empty. Sometimes these muscles are weak to empty the gallbladder, like in case of pregnancy, gallbladder stasis, fasting, total parenteral nutrition, and spinal cord injury, decreased bile salt secretion, like what's happening in pregnancy. So cholesterol gallstone, it is 51 to 99 of pure cholesterol plus mixture of calcium salt, bile pigment, and phospholipid. Pathological process, bile supersaturated with cholesterol and low bile acid concentration lead to unstable unilaminar phospholipid vesicles, which lead to nucleation of cholesterol crystal, and the end will be cholesterol stone. As you can see from the picture, here is the cholesterol stone. It's yellow crystal, and it's pure yellow. Pigment stone, which contain less than 30% of cholesterol, arise anywhere in biliary tree. They are two types, either black pigment or brown pigment. Uh, Black pigment stone, it is 20 to 30% stone are black, composed of insoluble bilirubin pigment mixed with calcium phosphate and calcium bicarb, associated with hemolysis. Any patients have, like, let's say, sickle cell anemia, hereditary spherocytosis, all those have high risk of hemolysis, and those having hemolysis will have black pigment stone. Patients with cirrhosis have higher instance of pigmented stone. As you can see, the gallbladder stone is black. Okay, so brown pigment, it's rare, but it's happened. We saw some patients having brown pigment stones, like patients having calcium bilirubinate, calcium palmitate, calcium citrate, and cholesterol. It's rare in gallbladder, whereas form in bile duct and are related to bile stasis and infected bile. Pathology due to deconjugation of bilirubin by bacterial glucuronidase. How we diagnose patients having gallstones? Based on the history and physical examination with some radiological study. We do for those patients abdominal ultrasound. Sometimes we need to do MRCP. In acute phase, the patient have right upper quadrant pain and tenderness that is exacerbated during inspiration, while your hand in the right upper quadrant keeping deep palpation. This is called Murphy sign. So Murphy sign, they examine the doctor. He need to put his hand on the right upper quadrant, pushing with deep palpation, and with deep palpation, the patient he will stop the inspiration. Positive Murphy signs suggest acute inflammation and may be associated with leukocytosis and elevated liver function test. Palpable non-tender gallbladder. This is called Courvoisier signs. طيب عبد الكريم, you will understand what is MRCP stands for in a while. Okay, so abdominal ultrasound, it is investigation of choice. So any patient having gallstone, we have to do ultrasound. Sometimes we need MRCP, but the ultrasound is the gold standard. Sensitivity more than 95%. 75% of gallbladder stones are radiolucent, so plain X-ray is not a beneficial to do an X-ray, abdominal X-ray. As you can see in the ultrasound here, this is the gallbladder. You can see in the left, this is the liver. This is the liver. Here is the gallbladder, full, distended with bile. As you can see, it's clean. Another cut, which is, you can see this is the liver and this is the gallbladder wall, and the content is clear. So these are normal gallbladder ultrasound. On this ultrasound, you can see the liver, you can see the wall, and you can see here some deposits. Down here, you can see some deposits. This is the gallbladder stones. So this patient is having gallbladder stones. Okay. Now we move to the MRCP. MRCP, which is magnetic resonance cholangiopancreatography. So this is an MRI. We do MRI for the gallbladder and the biliary system to check for any pathology that is missed by ultrasound. So the MRI or MRCP is more accurate than the ultrasound in showing gallstones and any biliary pathology. So it's an MRI. We use some contrast to be given intravenously, which is lipophilic paramagnetic contrast. It shows the hepatobiliary excretion. Contrast agents include gadopentate, dimeglumine, and gadolinium. So all these contrasts will be given through the IV line, and it will be absorbed from the blood to the liver, and the liver will excrete it to the biliary system, and we will see the image as you can see in this diagram. You can see this is the liver, here is the left hepatic duct, and this is the right hepatic duct. This is the biliary system showing gallstones. You can see it's full of contrast of stones. Okay, so treatment of gallstone, it's safe to observe a symptomatic patient. So a asymptomatic patient having no symptoms, he's not complaining. We just did ultrasound and we found gallstones. You don't need us to treat this patient. Patient with the symptoms or complication, we do for them laparoscopic cholecystectomy, which is removal of the gallbladder. Prophylactic cholecystectomy, it means patient has no symptoms, but you need to do for him laparoscopic cholecystectomy, like patient with diabetes and congenital hemolytic anemia. Okay, so on this slide, I will show you how to do the laparoscopic cholecystectomy. It's a simple. We do 4 incision or 4 small opening in the anterior abdominal wall. As you can see, we put our laparoscopic instrument and we come to the gallbladder. We grab the gallbladder, as you can see. We identify the Hartmann pouch. So this is the gallbladder fundus, this is the body, and this is the Hartmann pouch up to here. So this is Hartmann pouch. This structure is cystic duct, and this one is the cystic artery. We clean these overlying tissues here. We clean it and we do clips over the cystic duct. As you can see, clips. One clip here and 2 clip down. One clip here and 2 clip down on the artery, and we separate it. Then we take the gallbladder out. So this is on diagram, but here is the real picture, real operative picture. You can see down here is the common bile duct, and here this is the cystic duct. This is the gallbladder. We clean up the tissue here and we take the gallbladder out. Okay, so the gallstone complication. Why, if what will happen if we do not treat this patient with gallstones? So if you don't treat them, they do have potential complication in the future. Like they will have biliary colic, acute cholecystitis, chronic cholecystitis, embolism of gallbladder, mucocele, acute cholangitis, or acute pancreatitis. So acute cholecystitis, it's associated with obstruction of the neck of the gallbladder or cystic duct caused by stone impacted in the Hartmann pouch. Impacted stone cause mucosal erosion, allowing bile salt to act over submucosal tissue, as bile is toxic to these tissues, leading to infection and necrosis and perforation. So the etiology of or the causes of the acute cholecystitis, it's three: either mechanical inflammation because of increased intracranial pressure and distension with the resulting of ischemia of gallbladder mucosa and mold. Chemical inflammation due to release of lysoleucine and other local tissue factor. bacterial inflammation like E. coli, Klebsiella, Streptococcus, Clostridium, and Salmonella. So acute calculus cholecystitis. What is the meaning of acute calculus cholecystitis? Abdullah Haddad.
سامي يا دكتور.
What is acute calculus?
I think a stone stuck in the cystic duct or the opening of the gallbladder, and then it will progress to inflammation and infection.
Good. Why we didn't say acute cholecystitis only? Why we say the acute calculus only?
I think it's the same if it's acute cholecystitis and calculus.
حلو.
Or sorry, maybe acute cholecystitis has different causes.
طيب خلينا نشوف. علي العلي ايش رايك؟
والله ما ادري يا دكتور ليش يسمونها اكيوت كالكيوس.
طيب عبد الرحمن.
هلا دكتور.
What is why we say acute calculus?
اتوقع لانه في المين اوبننج يا دكتور.
Main opening. What is main opening?
والله يا دكتور ما عندي خلفيه بس ما عندي خلفيه.
دكريم.
أهلا دكتور.
Why we say acute calculus?
Is it related to calcium stones?
No. Safe.
لا أعلم والله يا دكتور.
ايه. طيب ممتاز. ممتاز. سيف وش ال types of gallstones؟
في عندنا الكوليسترول والبلاك وميكسد اللي هو بلاك وبراون وميكسد ستونز.
اوكي. جود. طيب معاذ.
دكتور
معاذ.
معاذ الغوينم ولا التميمي دكتور؟
الغوينم.
اي نعم.
سعودي.
اتوقع اي نعم دكتور معليش احسن مني اكتب بالانجليزي طالع بالعربي.
طيب ممتاز. detachment of stone. No.
دكتور ممكن تبقى من الموست كومن كوز.
ها؟
وسميناها اكيوت كالكولس وسميتنا الموست كومن كوز عشان نفرق عن الباقيات الكوز الباقي.
ايه. طيب let's take it simple. So we have gallbladder. The gallbladder contains stone. If this stone not treated, it will lead to acute calculus. Calculus in Greek, it's mean stone. So calculi in Greek, it is a stone. So acute calculus cholecystitis, that means it is an inflammation of the gallbladder because of the stone. Why? Is there any inflammation of the gallbladder because of no stone? Yes. There is another entity which is called acute calculus cholecystitis, which is acute inflammation of the gallbladder because of no stone. No stones inside the gallbladder, but there is an inflammation. Okay? So acute an inflammation of the gallbladder because of a stone inside. واضح؟
دكتور اكيد كالكولس هي في السلايد اللي قبله صحيح؟ الاشياء اللي قلناها 3 فاكتورز ولا ما له علاقه؟
Again?
اقول لك دكتور الاكيوت كوليسيستايتس النورمال اللي هي انفلاميشن اوف ذا جال بلادر تكون اللي قلناها السلايد اللي قبلها. لو ترجع السلايد اللي قبلها هذه الفاكتورز حقتها صح؟
هي مين هذا اللي يسأل عبد الرحمن؟
اي نعم.
So we don't have we have acute cholecystitis, which is the two types, either acute calculus or acute acalculus. So acute calculus, which is presence of inflammation because of the stone. acalculus, it is inflammation without stone. واضح؟ So الريسك فاكتور يعني الاكيوت كوليسيستايتس اللي احنا كنا نتكلم عنه قبل شوي it is acute calculus. يعني ما في شيء اسمه acute cholecystitis و acute calculus و acute acalculus. No. It's two types, acute calculus or acute acalculus. But most of the time when surgeons are saying acute cholecystitis, it means the acute calculus. Most common is acute calculus. So if you hear in the hospital or in the round, they said this patient admitted with acute cholecystitis, it means he had a stone. If they said this patient has acute acalculous cholecystitis, it means that he has acute inflammation without gallstones. واضح؟ All right. So acute calculous cholecystitis, which is the patient presents with pain in the right upper quadrant or epigastrium. This pain radiated to the right shoulder and tip of the interscapular region. Difference between biliary colic, which is severe, prolonged pain, fever, and leukocytosis. Examination, the patient have right hypochondrial tenderness. He has Murphy sign, and he has fever. With less than 10% of patients, they do have jaundice. Okay. فيصل وش الميرفي sign? What is a Murphy?
Actually, it's when the patient take a deep breath, he will feel pain. He will stop.
He will stop. So you will ask the patient to take a breath, or you just allow him to breathe normally?
I will push the site of gallbladder, and I will ask him to take a breath and hold it if he can.
Okay. If he stopped inspiration, that means he has positive Murphy sign. Good. So complication, if not resolved, if the acute calculus cholecystitis is not resolved, we'll have gallbladder empyema, wall become necrotic and perforate, abscess, which is perforate into peritoneal cavity with septic peritonitis. Investigation for the gallbladder or acute calculus cholecystitis, CBC or complete blood count, we will find the patient have high WBCs, white blood cells. LFT, which is liver function test, and ultrasound. So in ultrasound, we have certain findings on ultrasound. What are they? Presence of cholelithiasis, which is presence of stone, sonographic Murphy, gallbladder wall thickening with more than 3 millimeters, and pericholecystic fluid. These findings are the sonographic features of cholecystitis. Okay, so you will find a stone inside the gallbladder. You will find the patient have sonographic Murphy. Sonographic Murphy is a clinical Murphy, but with a probe of the ultrasound. So a technician of the ultrasound, when he has the probe of the ultrasound and he's doing the examination over the gallbladder, the patient stop taking inspiration. So that's mean he has sonographic Murphy. واضح؟
واضح يا دكتور.
واضح.
Good. Gallbladder wall thickening. The wall of the gallbladder will be more than 3 millimeters. Cystic fluid, which is fluid around the gallbladder wall. So the gallbladder wall will be like a circle, and you will have fluid around it. This fluid because of inflammation. Because of inflammation.
دكتور الفلويد هذا يطلع بالفاست هو نفسه اللي يطلع في الهيباتورينال انجل.
Sometimes طبعا هي الهيباتورينال ما لها علاقة what we are talking about, لأنه الهيباتورينال is something it's the angle between the kidney and the liver. It's not the gallbladder and the liver. صح؟
مستحيل بس أنا أتكلم يمكن الفلويد يطلع على بعضه.
ها؟
منه في الفاست يطلع بس في الهيباتورينال. ايه هذا نقرا منه.
So hepatorenal is kidney and liver. It's not kidney and gallbladder. As liver and gallbladder. Okay. واضحة؟
واضح.
ممتاز. So acute non-calculus or acalculous cholecystitis is acute and chronic inflammation of gallbladder wall or gallbladder can occur in absence of stones and give rise to clinical picture similar to the calculus cholecystitis. Occur in seriously ill patient like post-operative state after major non-biliary surgery, severe trauma, burn, sepsis. So in these patients, diagnosis is often missed and the mortality rate is high. Okay. Treatment for asymptomatic gallstones not require treatment unless the patient has porcelain gallbladder, which has an increased incidence of carcinoma, has a stone 2 to 3 centimeter, pediatric patient, and if he is immunocompromised, we do for him surgery. We do for him laparoscopic cholecystectomy. Symptomatic patient, we do for him laparoscopic cholecystectomy. Okay. More than 90% of cases, the symptoms of acute cholecystitis subsides with conservative measures like non-operative treatment, which is on 4 principles: nothing per oral or nil per mouth, intravenous fluid administration until the pain resolves, administration of analgesia, administration of antibiotics. What is the choice of antibiotic? Broad spectrum antibiotic, effective against the gram-negative aerobes, is the most appropriate, like cefazolin, cefuroxime, and gentamicin. Chronic cholecystitis, it's a chronic inflammation of the gallbladder. Symptoms: recurrent attack of upper abdominal pain, often at night following meal. Clinical picture similar to acute cholecystitis, but mild. Pain recovers spontaneous or following analgesic and antibiotic. Management is laparoscopic cholecystectomy. Why we say that chronic? Because the patient will come to you and he said, I have this pain continuous for 1 month, and we do an imaging. You see the finding of the ultrasound, the pericholecystic fluid thickened wall, it's there. So he has a chronic cholecystitis. Emboyema of the gallbladder. What is emboyema of gallbladder? It's results from progression of acute cholecystitis with persistent cystic duct obstruction, leading to superinfection of with pus formation. So you will find the gallbladder super infected, and what is inside the gallbladder? Stone and pus. Okay. Clinical fever: high grade fever, pain and tenderness, override hypochondria. Treatment: IV antibiotic like cefotaxime, ceftriaxone, drainage, and we do for them later laparoscopic cholecystectomy. Complication: they might have septicemia and they might have rupture and peritonitis. Mucocele. Mucocele is obstruction of the gallbladder cystic duct. And this obstruction caused by a stone in the neck of the gallbladder, which is a Hartmann pouch, without any infection of the or inflammation. So the gallbladder is distended over a period of time by mucus, not a pus. So when in this content is pus, it will be emboyema. When it is only mucus, which is a mucocele, clear transudates, it will lead to mucocele of the gallbladder. Patient usually remain asymptomatic, but chronic right upper quadrant pain may be there. Clinical feature: visible, easy, palpable, soft mass, non-tender mass in the right hypochondrium, and dyspepsia. Investigation: we do ultrasound and liver function test, and the treatment is laparoscopic cholecystectomy. Acute cholangitis. caused by bacterial infection of the bile duct secondary to CBD stone. معاذ الغوينم.
سم دكتور.
What is the CBD?
ما عندي فكرة.
أمير السعد. أمير. أمير السعد. أمير السعد وينه؟ عبد الرحمن.
دكتور هذه يصير في ستونز في البايل دكت.
أمير السعد.
من 10 ل 20. أمير السعد موجود، مكتوب إنه موجود.
المفروض إنه موجود. وينه؟
وديك عليه دكتور.
No, where is he? He is attending, and always we do attendance for any for few that presume he is attending.
أمير تبغى أتصل عليه دكتور؟
No, where is he now here in the blackboard?
He's there.
No, he's not. He's not answering.
Yes, I know, but he's gonna participate. Yes, I know. He's not answering. ممكن راح يجيب مويه ولا راح الحمام ما أدري.
مين راح الحمام بعد من العيال؟ فيصل عويس.
سامي يا دكتور.
ايه طيب لؤي الشمراني.
أهلا دكتور.
ايه عبد الرحمن. ايه this is my first time and this is the last time for this group to have online lecture, and one of the student, he is attending in the blackboard but he is not physically attending. If he is not going to attend, do not let him come to the blackboard, please, because we do an effort with PowerPoint. We start preparing and we give maximum effort to explain to you, and by easy someone is attending on the blackboard and he is not physically in front of the screen. Okay, so next time if this happen when he's attending in the blackboard and he's not physically attending, I will stop giving the presentation and you can go and read it for all of the group.
No, inshallah, doctor, whatever you want, I will do it, inshallah. I promise you, inshallah, to be the first time.
Okay, good. So acute cholangitis is an surgical emergency, and it is very dangerous. The patient can die with the acute cholangitis. It is a CBD stone, which is common bile duct stone leading to obstruction. This obstruction giving the infection. So نشوف فيصل, what is the difference between CBD and common hepatic? فيصل عويس.
سامي يا دكتور. في ثلاثة فيصل. أبشر.
فيصل عويس, what is the difference between CBD and common hepatic?
والله عندي ما أدري.
Hmm?
CBD stands for what?
Hmm?
CBD
Hmm.
stands for what?
طيب we'll let you know. عبد العزيز الذيب, what does the CBD stand for?
CBD اللي هو common bile duct يا دكتور ولا؟
What is the difference between CBD and common hepatic?
الكومن هيباتيك إذا صار مثلا فيه ستون راح يقفل على البايل اللي موجود اللي جاي من
two different structure. What is the difference between CHD and CBD?
الاوبننج حق لا اله الا الله حق البنكرياس يجي في السي بي دي لكن ما يجي في الكومن هيباتيك. ما عرفت اشرحها يا دكتور بالضبط بس.
No, not a pancreas. أحمد العنزي. What is the difference between CBD and common hepatic?
اتوقع مثل ما قال عبد العزيز اوبننج اليوم
إليوم؟
اليوم اللي بين الهيباتيك اليوم هيباتيك اليوم
Hepatic ileum? What is hepatic ileum?
الباس between the hepatic and between the bile duct and the ileum يكون مقفل.
What is ileum? Ileum اللي هو small bowel?
جيجنوم.
Jejunum? No.
جيجنوم.
Jejunum? لا.
جيجنوم.
No. Not ileum, not jejunum.
جيجنوم أقول دكتور.
Biliary system draining in the duodenum. It's not in the ileum or jejunum.
So جيجنوم يا دكتور مو جيجنوم.
ها؟
قاعد أقول جيجنوم مو جيجنوم. جيجنوم.
Duodenum. No, it's not duodenum. So the difference between common hepatic duct and common bile duct, we have, I explained it already in the beginning of the lecture, but it seems that no one is looking. So we have two structure. We have hepatic duct right and left hepatic duct. These hepatic duct join together to form common hepatic duct. This common hepatic going down, and the cystic duct insert to the common hepatic duct to form the common bile duct. So the difference between common hepatic duct and the common bile duct is the cystic duct insertion. So when the cystic duct join them, it becomes a common bile duct. Clear?
Clear, doctor.
Good.
واضح دكتور.
So the acute cholangitis, it's occur in patients with pre-existing biliary problem like cholelithiasis, cholelithiasis, and biliary stricture or tumor. What is cholelithiasis? It is gallstone. What is cholelithiasis? Cholelithiasis is stone in the CBD. So the stone in the CBD we say as cholelithiasis. Okay. Clinical features. The patient presents with Charcot's triad. This is the triad of presentation. We have patient jaundice, fever with rigors, and right upper quadrant pain. Clear? Abdurrahman al-Nizzi, what is fever rigors?
فيبر يعني حرارة مع رعشة دكتور.
حرارة مع رعشة. So يجي البيشنت قدامك يصقصق سنونه كأنه بردان. So fever with rigors, jaundice, and right upper quadrant pain. This is called Charcot's triad. Okay. What is Raynaud's pentad? Raynaud's pentad. ايه.
الشاركة العياد هذا ما يجي في كل الجالبلادر انفلاميشن بس في الكولنجايتس مو يجي في مثل جوندس اي بلاريتري
ها again
في اي بلاريتري اوبستراكشن اتوقع بس في جوندس ورايت ابر كوادرت بين وفيفر يعني هذا موجود في كل المفروض
no يعني انت you think انه patient عنده gallstone in the CBD he must have right upper quadrant and fever with rigors.
اي ثينك هذا يجي في كل مكان يعني في سواء في السي بي دي في كل اي انفلاميشن بالجول بلادر بيصير زي كذا.
انت you think
بس سواء due to gallstone ممكن obstruction بال 3 او في نفس الانفلاميشن في الجول بلادر نفسها يطلع الكارتون لانها هو الجوندس والفيبر ورايت ابر كوادرنت هذه كلها تمثل على الجول بلادر والكارتون.
عيد again ما سمعت.
اقول لو صار في سي بي دي ستون او جول بلادر ستون نفسها او انفلاميشن بالجول بلادر يطلع الاعراض الثلاثه هذه
اللي هي
جوندس والفيبر والرايت ابر كوادرنت بين.
اذا جاك جول ستون بيصير عندك جوندس
اذا صار سيمتوماتيك اللي هو انفلاميشن اللي هو سكر العنق الجول بلادر.
ايوه ايش يصير؟
جوندس وفيبر ورايت ابر كوادرنت.
يعني any patient عنده جول ستون they present with jaundice صح؟
اللي يصير معها obstruction جول ستون with obstruction.
كيف يعني جول ستون with obstruction؟ يعني الستون موجوده في الجول بلادر يعني هنا انا بشوفها بالسلايد.
لا اذا مو مترسب تحت تتكلم سيمتوماتيك اللي صار obstruction.
من اللي يتكلم الان؟ عبد المجيد؟
عبد المجيد.
اوكي طيب شوف عبد المجيد الان هنا يعني انت الحين you ask ولا you think and
I ask to think نفس الوقت.
اوكي ask give me a question. انا بمسك سؤالك ماني ماسكه. هنا عندك السلايد show me.
انا اتكلم بشكل عام اذا في اي مكان يصير فيه obstruction بالبلد 3 سواء في الجول بلادر في العنق بدايه الجول بلادر او في الهيباتيك داكت او في البايل داكت او في السيستيك داكت يطلع كلها تتوقع الكاركت ساين كامل.
تطلع الساينز كامله.
ايه هو الجوندس والفيفر ورايت ابر كوادرنت.
Okay, so first, any patient has gallstone, which is a stone inside the gallbladder, he will not have jaundice. Why? Because the gallbladder stone is not compressing the biliary tree. The flow of bile from the liver to the duodenum is open. So this channel is open, no obstruction is here. So the patient to have an obstruction, it should have a stone inside the biliary tree, either in the common hepatic duct or in the common bile duct, not the cystic duct. If the patient has cystic duct stone, it will not lead to obstruction unless it is a short, and this is a small entity, very rare entity called Merisi syndrome, and we will understand it later on. So not all patients having gallstone, they have jaundice. You are wrong. Patient having gallstones and gallstone lead to inflammation, it will have acute cholecystitis, but he will not come to you at jaundice. He will come to you with fever and right upper quadrant vein. Once he has jaundice, that means the gallstone moved from the gallbladder to the biliary tree. So this we call it as acute cholecystitis with what? With CBD stone. So first, to diagnose acute cholangitis, you have the patient to have what? To have fever with rigors, not only high-grade fever or low-grade fever. No, fever with rigors, clinically rigors. This is one. Two, he will have jaundice because of the CBD stone. He will have right upper quadrant pain. Why he has jaundice? He has jaundice because he has stone in the CBD or common hepatic duct. This stone lead to super infection and stasis of bile, and the end will be pus inside the biliary tree. So acute cholangitis is infection of the biliary tree. It's not obstruction. It's obstruction initially. This obstruction lead to stasis. This stasis lead to what? Lead to super infection. So acute cholangitis, we said that we have Charcot triad. We said we have Raynaud Bentad. Raynaud Bentad is the same as Charcot's, but we add two more. So it is a combination of Charcot's plus shock and altered mental status. Okay?
So, Doctor, it's a character feature of acute cholangitis? It's only
features
character
of-
face, only
Yes.
character feature for acute cholangitis.
Yes, all are characteristics of acute cholangitis. So you have a patient having jaundice, fever, right upper quadrant pain. When this is Charcot's triad, added to it shock and altered mental status, it is called Raynaud Ventad. So here how we can identify it clinically. Abdullah Ataibi.
سمي دكتور.
What is the shock with acute cholangitis?
Shock.
Yes. And I said Raynaud Ventad, combination of Charcot's shock and altered mental status. What type of shock?
Distributive shock.
What kind of distributive?
Anaphylaxis also.
Huh? فيصل عويس.
Septic shock دكتور.
Septic shock. إياد هيجان endocrine. No, it's not endocrine, Iyad. Okay, so you are right, Abdullah Faisal, this is a septic shock. Good. So treatment is antibiotic, relief of biliary obstruction by ERCP, BTC, and you'll understand what is ERCP, BTC, and removal of underlying cause if possible. So ERCP, it is an endoscopic retrograde cholangiography, which is endoscopy. You go from the mouth, endoscopy, until we reach the second part of the duodenum. We go to sphincter of Oddi, and we inserted, as you can see from the picture, from the scope, we inserted the catheter through the biliary tree, and we extract the stone. You can see here, this is the sphincter of Oddi. We inserted the catheter inside, and we drained the stone. See the yellow discoloration? These are small stones coming out. Okay, so gallstone ileus is referred to mechanical intestinal obstruction resulting from passage of large stone into bowel lumen. It's interduodenum through the cholecystenteric fistula, which is site obstruction usually at ileocecal valve. Stone around 2.5 centimeter predisposed to fistula formation. Clinical feature: patient will have pain in the abdomen with feature of intestinal obstruction. Treatment is laparotomy with stone extraction and closure of the small bowel enterotomy. So how we can see it, to understand it, this is the gallbladder, and the stone is here in the gallbladder neck or gallbladder body, because the gallbladder is always adjacent to the duodenum because of inflammation or adhesions. These stones compress the duodenum, especially if it is more than 2.5, will pass to the duodenum, and it will cause small bowel obstruction. Cholesterolosis, which is a strawberry gallbladder state, the interior of the gallbladder looks something like strawberry in patient with this condition. Yellow speaks, which is submucous aggregation of cholesterol crystal and cholesterol esters correspond to the seeds. So it just look like the strawberry appearance. It's associated with cholesterol stone most of the time. Gallbladder polyps. Gallbladder polyp, it is an elevation of gallbladder mucosa that protrude into the gallbladder lumen. 5% prevalence in the global adult population, only 5% of those are true polyp. Increased detection due to frequent use of abdominal imaging. Common detected on ultrasound of the abdomen. Previous prevalence, which is 0.3 to 9.5. Treatment is laparoscopic cholecystectomy for polyp more than 10 millimeter or 1 centimeter and symptomatic patient. Patient have symptoms, you identify, you did a gall ultrasound, and you find polyp. Carcinoma of the gallbladder. Cancer of gallbladder is rare, which is occur in elderly. It is an aggressive tumor, poor prognosis except when incidental finding after cholecystectomy. Incidence gallbladder cancer in the fifth most common GI malignancy. Etiology is the cholelithiasis. So gallstone can lead to cancer if it is big inside. So large stone more than 3 centimeter associated with 10-fold increased risk of cancer. So pathology between 80 to 90% of gallbladder tumor are adenocarcinoma. This is 80 to 90%. Squamous cell squamous oat cells and other anaplastic lesion can occur. Histologic subtypes of gallbladder adenocarcinoma include papillary, nodular, and tubular. The treatment is surgery always, which is the only curative option of gallbladder cancer. Pathologic stage of gallbladder cancer determine the operative treatment for patient with localized gallbladder. So it's depend on the stage of the cancer. So if the tumor is limited to the muscular layer of the gallbladder, which is a T1, which is a TNM classification. T1 is TNM classification of gallbladder cancer, are usually identified incidentally after cholecystectomy for gallbladder disease. Laparoscopic cholecystectomy is the treatment for gallbladder cancer, only limited to the muscular layer of the gallbladder. When the tumor invade to perimuscular connective tissue, now it is more advanced. So perimuscular connective tissue without extension beyond the cirrhosis. This is called T2. The treatment is cholecystectomy, okay, with something more. We called it extended cholecystectomy. Extended cholecystectomy, it means taking the gallbladder out, resection of segment 4B and 5 of the liver, lymphadenectomy of the cystic duct and pericoidocal lymph node, portal, and right celiac posterior pancreatic duodenal lymph node. So when the tumor extends beyond the perimuscular connective tissue, we do extended cholecystectomy. What is extended? It is taking the gallbladder out, taking segment 4 and 5 of the liver out, lymphadenectomy of cystic duct and pericoidocal lymph node, right celiac and posterior pancreatic duodenal lymph node. Right. When the tumor grow beyond the cirrhosis or invade the liver or other organ, there is likelihood of intraperitoneal distant metastasis. If no peritoneal or nodal involvement, complete tumor excision with extended right hepatectomy, which is segment 4, 5, 6, 7, and 8 must be performed. So we do cholecystectomy with right hepatectomy. Okay. Any question شباب؟
دكتور بس عندي سؤال لو سمحت.
تفضل.
دكتور انت قلت large stones over 3 centimeter are switched انت تقول دكتور الحين ممتاز.
بعيد.
الان طيب.
اي كويس.
الو. انت تقول لي دكتور large stones 3 centimeters are switched with 10-fold risk of cancer في الجلبلادر.
Yes.
هل هذا معناه اذا شال اذا سوى كولستكتومي ولا بدون ما يشيل كولستكتومي؟ ولا اذا كان في ستونز وشالها الريسك؟
No, we don't take the stone. We take the gallbladder with the stone. So if he has a stone more than 3 centimeters, you have to do for him surgery, even if he has, let's say, minimal symptoms. Why? Because risk of cancer is very high. Clear? طبعا when we do for him cholecystectomy, let's say patient has 3.1 centimeter and he has symptoms. We take the gallbladder out. When we send it to pathology, the pathologist will see all gallbladder we take it from patients, we send it to pathology, and we see the result of the pathology after 1 week. We review it with the patient. We said, okay, your gallbladder is completely intact, no tumor or cancer. Okay.
سؤالي الدكتور سمعت.
تفضل.
الحين يا دكتور كل الجول ستونز الكومبليكيشن حقتها اللي اخذناها اللي هو اكيوت كولنجايتس واكيوت كالكولوس ولا كالكولوس هذه اللي ما لها علاقه في الجول ستونز.
صحيح.
يعني اهمها تكون الجول ستونز بعدها الكومبليكيشنز حقتها.
كيف اهمها؟ ماني فاهم.
يعني هي اذا صار في جول ستونز يعني هي تصير
أيوه.
يعني الكومبليكيشنز حقت الجول ستونز اللي هو الاكيوت كوليسيستايتس واكيوت كولنجايتس وتيومرز وكذا. طيب التريتمنت حق الاي ار سي بي هذه اذا كان بالبليري تري فقط يعني.
انا ماني فاهم سؤالك.
دكتور انا شوي مضيع فتح المحاضره.
انت مضيع السؤال بالضبط. ها
انا اقصد الاي ار سي بي حق عشان نشيل الستون بس اذا كان في البليري تري. اما اذا كان الستونز في الجول بلادر اشيل الجول بلادر كامله كوليسيستكتومي.
بالضبط. If there is stone in the biliary tree, in the CBD or common hepatic, you do ERCB to take it out. Put a catheter inside and extract that stone, so he will not have any obstruction. So if he had jaundice or he have jaundice or cholangitis, he has CBD stone, we take the stone out and then we do cholecystectomy. Okay.
ممتاز جدا يعطيك العافية.
الله يعافيك. false cholecystectomy يؤثر على اللايف. هل يؤثر على اللايف ستايل؟ ماني فاهم. عبد الله عتيبي يتكلم عشان افهمك.
يعني دكتور اذا سوينا كوليسيستكتومي المريض ما كان
علي صوتك عشان ما اسمعك زين.
اذا كان not indicated during the surgery فتح وما يحتاج كوليسيستكتومي وشلت الجال بلادر هل يأثر على المريض؟
No. ما يأثر على المريض. Because the gallbladder is only a reservoir for the bile. خزان for the bile. It's not functioning in bile secretion. It's functioning in bile concentration. It take the bile in and store it and concentrate this bile for use later on by digestion. So it's not affecting the patient life. The patient will continue his life without a gallbladder. False cholecystectomy, I don't think it is a valid name or valid surgery for cholecystectomy. False cholecystectomy, that mean what I understood from your question, this is malpractice. دكتور patient ما عنده أي symptoms أخذ الدكتور سوى له lab cholecystectomy. This is malpractice. Okay, but it's not an entity called false cholecystectomy. ما في شيء اسمه false cholecystectomy.
يعني دكتور ما في زي الابندسايتس. يعني الابندسايتس may have false appendectomy.
ما اسمعك والله. علي صوتك عشان اسمعك.
يعني مو مثل الابندسايتس يا دكتور. في مصطلح في الابندسايتس.
وش فعلا؟ علي صوتك اعلى ممكن.
يعني دكتور مو مثل الابندسايتس. الابندسايتس
وش فعلا؟
في شيء اسمه فولس نيجاتيف ابندسايتس. 23% يكون غلط او
appendicitis false negative appendicitis.
صوتي واضح يا دكتور.
اعطيني.
انا كتبت الدكتور فولس كوليسيستكتومي على انه في مثل الفولس ابندسكتومي. قلت ممكن هل الفولس ابندسكتومي هذا فاليد ولا نوت فاليد اصلا؟
طيب false appendectomy false appendectomy is an old entity. Old entity, why? Because previously we are taking the patient on clinical diagnosis. يجيك patient لل ER, we do for him clinical diagnosis, history and physical examination. You touch his abdomen and you do certain clinical signs. If he has this sign, he will have appendicitis. Take him to OR. That's why we have patients having false appendectomy, or let's say negative appendectomy. Okay, when the radiology advances, we have CT scan, we have an ultrasound. So the number of false appendectomy or false appendicitis became less. And in the current use of the CT scan, because now if we have patient questionable having appendicitis, we do for him CT scan to confirm it. So it is here, it's available that we have false appendectomy, but it's not as common as previous. So for the last 3 years, I never saw a patient having false appendicitis or false appendectomy. Why? Because when we are in doubt, we do CT scan. When we are in doubt, we do ultrasound to confirm it. Okay?
أشكرك دكتور.
عفوا.
دكتور بالنسبة للحضور يا دكتور،
مين أمير السعد وينه؟
بالنسبة توني بتكلم في الموضوع دكتور، بالنسبة للحضور إذا ودك، أو قلت توني بكلمك يعني بالنسبة للحضور إذا ودك يصير فقط اللي يرفع يده زي كذا زي ما أنت شايف الحين. يا شباب ارفعوا يدكم بالله اللي مو اللي حاضرين. يصير فقط هذول اللي زي كذا هم اللي يكون حاطين. This is my idea to do it.
طيب اوكي.
اسوي لك سكرين شوت على اللي رافع يده
وينهم الشباب؟ كلهم رفعوا الحين؟
يا شباب كلكم ارفعوا يدكم عشان التحضير.
أمير وعبد المجيد وعبد المحسن. أمير عبد المجيد عبد المحسن. ها؟
أمير دكتور.
ارفع يدك ارفع يدك يا عبد المجيد.
يلا سلام.
أمير وعبد المحسن الغامدي ما هم موجودين، صح؟
عبد المحسن.
طيب ممتاز. خلاص اوكي، يعطيكم العافيه. نتقابل في الابستراكتيف جوندس.
شكرا دكتور.
عفوا. هلا.